afternoon, everyone. My name is Dr. Jerome. I'm the Chief Medical Officer of Hartford Healthcare. On behalf of Hartford Healthcare, I'd like to welcome all the members who are in the room here today. I also would like to welcome Surgeon General Dr. Adams, Senator Blumenthal, and other members of the State and Department of Public Health at this time who's in the room here. At this time, I'm going to go over a couple of things. This is a very jam-packed agenda for Surgeon General. He's trying to cover a lot of areas, so we're going to be as crisp as possible in introductions and conversation. We will have a lot of discussions, especially in the clinical front with Surgeon General, especially the topic he's very passionate about. I'm going to introduce Dr. Costa, who's going to take this from here. Dr. Costa is a graduate of Yale College and Yale School of Medicine. He's also the president of our Hartford Medical Society, and in partnership with Hartford Medical Society, we have the honor of hosting Dr. Surgeon General Dr. Adams here today. Dr. Costa.
Good afternoon, and welcome, and thank you for sharing this time with us. I'm Bernard Costa, former Hartford Hospital urologist, now president of the Hartford Medical Society. Before I introduce our speaker, I'd like to take a few moments to talk about the Hartford Medical Society. Our association was formed in 1845, which is about 10 years before that huge boiler explosion that led to the founding of this institution. Our mission at Hartford Medical Society is always to promote learning, camaraderie, and community service among the medical community in Connecticut. Today, with events like this one, we encourage medical professionals to step away from their desks, learn the latest news, and share in collegiality. I'm sure some of you remember when lunchtime is where we met in the doctor's dining room and we exchanged stories. That doesn't happen anymore, and hopefully through the HNS you can partake in that again. So HNS is a fantastic organization, and I ask each one of you to consider becoming a member. Thank you.
At this time, I'd like to introduce Mr. Jeffrey Flax. Mr. Flax is the president and the chief executive officer of Hartford Healthcare. Hartford Healthcare is a truly integrated healthcare system, one of the only ones in the state of Connecticut, and he oversees 30,000 employees and provides community service and patients access to more than 350 access points across the state of Connecticut. Jeff is a proud Connecticut native and is passionate about the culture of organization. What I've learned working with Jeff for 9 years and closely so in the last 6 months about his passion about the values and our mission statement for Hartford Healthcare. He embodies the values which are consistent with our inclusivity, diversity, and commitment towards the community. And he's creating an organization that values its employees' wellness and celebrate diversity and inclusion. At this time, Jeff.
Thank you. Good afternoon. And certainly, Vice Admiral Adams, it's a true honor for us to have you on this campus today and be participating in today's forum. We're very, very grateful. Everyone here knows that within Hartford Healthcare, we have great respect, great appreciation for the incredible legacy that we have as an organization and the imprint we've made in healthcare going back nearly 2 centuries. So today I begin with the Vice Admiral or Surgeon General on campus with a statue that sits in Bushnell Park, right across from the Capitol, and we see Dr. Horace Wells. Dr. Horace Wells is often credited with being the father of anesthesia, certainly the co-founder of anesthesia. So having the Surgeon General and anesthesiologist here today, we really wanted to recognize with the Hartford Medical Society as our partner that we have a long tradition here of innovation, of firsts, and people who care deeply about shaping healthcare in America. And one of our proudest forebears in that regard is Dr. Horace Wells. So as I begin today to set some context for today's discussion, I begin with what we've created in Hartford Healthcare. And we've created a true system of care. Today our system has just about 380 locations. We'll cross 400 in the next 7 months with a number of them under construction. And what we've built is not bricks and mortar, but we've built a system of care designed around trying to optimize quality, access, and affordability. When we look at the system of care that we've created, we're transforming healthcare in America today. And we're doing it by making investments and changing the way we deliver services. So our health system is not working hard to protect or advocate for the status quo, but we're embracing the need for change and disruption to deliver services dramatically differently. And when we look at the system of care we've created today, it's founded with one electronic health record. That health record today ranges from our home health care services to our urgent care capabilities to primary care to specialty care in every other one of our centers. So as we've built a capability to care for the patient at the center of what we do, our vision is to be most trusted for personalized, coordinated care. And I do believe each one of us as citizens within our state can see and feel the tangible differences that have been made over the last decade, as now patients are starting to really appreciate that we're making demonstratively higher levels of quality. We are clearly driving costs down in terms of affordability of services, and we're working hard right now to revolutionize access. So this begins with an investment we made several years ago, one of the first in the country, and this is in Newington, our Care Logistics Center. And our Care Logistics Center changed the way we allocate beds, the way we allocate our human capital, the way we allocate our high technology services, and the way today we accept over 8,500 patients who are admitted patients in other hospitals throughout New England and beyond, and now come to our organization. And because we created the Care Logistics Center, we have dramatically removed dwell time. And we today accept effectively 100% of patients who need a higher level of care. And this was a very disruptive approach. And what's next is we'll be commissioning just in 60 days our access center. We're going to go beyond our hospital beds. We're going to go beyond our high-tech services. And we're going to take more than 1,000 physicians. And we're going to take the schedules of those physicians and put them with predictive analytics in an access center that will be built in downtown Hartford, staffed with over 300 new jobs that are being created. And ultimately, we're going to dramatically remove the barriers to care. We're going to advance access significantly. And we're going to be able to help accelerate people's ability to get well and to have the right preventive services in the right place at the right time and ultimately at the most effective price point that we can. So I couldn't be more excited with the work we're doing around access. Secondly is our being disruptive. So today we have 24 urgent care centers built across our state. We're doing over 224,000 visits within these centers. These centers took visits that used to occur in the emergency department just 2 years ago. And those visits were reimbursed at north of $1,000. To today, those same patients are being cared for more expeditiously at a dramatically lower price point, often slightly more than $100. So to do that, we had to build a new network of services. We had to embed our electronic health record. We had to expand our clinicians. But we're doing it not episodically, but we're building it as part of a system of care. And certainly, as we do that, the goal is to drive quality. And I bring this image forward because this is one of our friends, many people in this room, someone we saw as great inspiration, Andy Busek. And Andy was our first heart transplant patient done in 1984. When we think about what quality means, what access means, what having the highest level of services mean within our region, think about the courage that Andy had. When Andy went forward in 1984 as our first heart transplant program, there were less than a handful of programs in the country providing that level of service. A previous patient had been attempted and passed away at a different hospital in Connecticut, and Andy went forward here. Now, what I love about this image is taken 40 years after his heart transplant, before he had children, before Andy was married, before Andy had grandchildren. before Andy ultimately retired working for UPS. And I remember meeting Andy on numerous occasions when he'd come on campus. I said, he's the ultimate inspiration because he had the courage to advance, to partake in this innovation, and ultimately defined the culture of this institution. And Andy went on to have an incredibly full life. And I just look at that image and I look at his eyes and you think about 40 years later what he experienced. And to this day, he is one of the longest surviving heart transplant patients on record. So as we drive quality, today we're in the top decile in the United States around heart and vascular-related services. We enjoy a 3-star rating in 3 of the 4 CMS guidelines. Our services continue to define themselves by quality, and we continue to focus on improving quality tirelessly within this institution. So having the Surgeon General here today, partaking in the national dialogue, it's part of who we are. It's part of the fabric of this organization. And I'm very, very proud for another historic moment for this organization. We're very grateful. Today we're talking important about the incredibly focused effort we've had around our efforts around opioids, but at the same time we recognize the coronavirus dynamic that's going across the world today. We are here in this region, the Safety Net Hospital, and we have been since our founding, we were founded in 1854, and it does define our health system. And I'm so proud of the 30,000 people who work here and the efforts we're putting in place to respond to these emergencies. And we are certainly partaking with all of our government officials, and we will pledge and do whatever is possible to protect the safety, health, and well-being of our residents, our caregivers, and every person within our community. So with that, I have the pleasure, and I want to invite forward Senator Blumenthal to come forward. Senator Blumenthal is no stranger to this campus. There is no elected official who's here more, quite frankly. He is absolutely passionate about healthcare. He is a great advocate for healthcare and for services in this region, and he's someone who is completely accessible to us and approachable, and who cares very deeply about these matters. And we're very, very honored that you would join us today too, Senator. Thank you so much.
Thank you so much, Jeff. It's true, I'm here a lot. I don't know whether that's a blessing or a curse, but I'm very proud of the times that I have been here advocating for public health issues on drug shortages, on flu shots, on misleading and deceptive ads using celebrity influencers for diet plans. There is no institution in the state of Connecticut, maybe none in the country, that does more for public health than Hartford Healthcare. And I just want to extend personal thanks to you, Jeff, and to all of the staff and the docs who are part of that Hartford Healthcare network for all the great work that you do, not only in the professional care you provide, but the awareness and education that you do. The Surgeon General and I have just been in Rocky Hill at the state lab. By the way, I learned from the Surgeon General the correct way to wash your hands. You're never too old to learn how to wash your hands. I'm also pleased to be with, and honored to be with him today to say thank you to the larger Connecticut Health Network, and on issues like the coronavirus, which brought us to the state lab this morning. We can be very proud that our health network, and Hartford Healthcare is a vital part of it, has been at the forefront, literally the tip of the spear, in helping to work against the spread of this disease, and equally important, to provide facts, because facts defeat fear. Prevention and preparedness stop panic. And what you are doing as professionals in your communities to spread awareness and, frankly, respect for science, I think is tremendously important. And I just want to say, finally, I'm going to continue fighting for science, for increasing the funding for CDC and NIH, not slacking it, for doing more on global health, not cutting it, to reimburse. diverse communities, state and local health officials, and hospitals. I just want to stress, and hospitals, for the additional costs that you will face as a result of measures you take, whether it's buying new equipment or training new staff or hiring new staff, because these costs should be the burden borne by the federal government. Our hospitals are already hard enough pressed fiscally that we shouldn't impose that additional burden. Let me just say finally why I'm so honored to be with Dr. Adams today. You know, he has been at the forefront not only of this latest public health crisis, and he's had the courage to call it what it is, but also other public health challenges. I've been here on the issue of vaping. He has been front and center as far back as 2018, and I know because I've been working on it, as well as tobacco prevention in these years. He's been at the forefront of that fight, as well as flu and vaccinations on all kinds of public health issues. He has had the courage to speak truth to power. That's the kind of person we need in that job in Washington, D.C. So very proud to be with you, Surgeon General, Vice Admiral, Dr. Adams. Thank you.
It is afternoon now. Good afternoon, everyone.
Good afternoon, sir.
It is wonderful to be here to address you today. You know, I got a little scared when I came in because they have our names on the table, and I had Senator Blumenthal on one side of me. His name was there. On the other side, it said Jeff, and I thought it said Jeff Flake. Follows the DCC. Jeff Flake is politically a little bit different than Senator Blumenthal. And I thought they intentionally put me in the middle of the two to referee and keep them away from each other. But, you know, the interesting thing about that is that health should be nonpartisan. I don't even say bipartisan. Health should be nonpartisan. One of the things that I dream of is a day when we can have folks from all different political persuasions sitting down and dealing with our most difficult issues. And on vaping, on the opioid epidemic, on coronavirus, I quite frankly have seen a lot of folks coming together. And I really want you all to think about how you all can lead discussions in our communities that won't just promote health, but that will also help bring people together in ways that we're having a little bit of difficulty doing that now in other parts of society. I'm here today to talk about opioids, but we can't have a conversation without talking about coronavirus. Important for folks to know that the Senator and I were just with Governor Lamont and the State Health Commissioner had a press conference. And here are the key points. We are seeing increased cases. We're seeing likely community spread across the country, but we expected this was going to happen. We knew this was going to happen. There was no way you're going to have 80,000 cases in the rest of the world and have 0 cases in the United States. So we knew it was going to happen, but we also know what to do. And I need you all to help the people of Hartford, the people of Connecticut understand that we've been here before. How many of you all were around during H1N1? How many of you were around during SARS? How many of you were around during MERS? And keep your hand up if you were around in 2009 when we had the flu situation then. You've done this before. We need folks to understand now is not the time to panic. It's the time to prepare, as the Senator said. But we have the resources, we have the tools, we have the playbook. We simply need to implement it. We also need to help folks risk stratify, and humans are terrible at this. We just are. We're terrible at risk stratification. We're terrible at thinking through what is the thing that is most likely to harm me, but that I'm underestimating, versus what's the thing that I'm terrified and shaking in my boots about that's unlikely to happen to me. And the fact is, we've had over 18,000 people die from the flu in this country this year. It drives me bonkers when someone comes up to me and says, "Oh my gosh, Doc, how do I protect myself from the coronavirus?" And I say, "Well, have you gotten your flu shot?" "Nah, I don't do that." Oh my goodness. Getting your flu shot is not only more likely to protect you from the exposure you're going to face in your communities, but it also keeps your beds, your resources free because you're not overflowing with flu patients, so that if we actually do get a coronavirus case, we can take care of it and not keep them out of the hallway or have to send them somewhere else because their ICU is full with people who got the flu but maybe wouldn't have gotten it if they'd gotten a flu shot and taking basic precautions. So we need you all to help the community understand the steps that they can take. We need to again, calm them with the fact that that this is going to get worse before it gets better, but that we know how to respond and that we know what to do. There's a whole lot of other things out there that are more likely to put you in the hospital and kill you right now than coronavirus. We also need all of you to have a high index of suspicion for folks, healthcare providers. We need you to pay particular attention to infection control. We saw what happened in the long-term care facility in Washington. That's not the coronavirus's fault. That's the fault of poor infection control. And I dealt with CRE outbreaks and other outbreaks, and when I was State Health Commissioner of Indiana, we need to make sure now we are being more vigilant than ever with infection control practices so that we can protect our patients. We need you all. We expanded the definition of persons under investigation last week, and that was at the request of providers who say, give us the flexibility to actually be able to test people if we think they're suspicious for coronavirus. We need you all to keep up with what's going on at cdc.gov so you know the parts of the planet that are most at risk for coronavirus. So if you've got a patient, by golly, you know that they were just in northern Italy 2 weeks ago and that there's someone who is at higher risk for coronavirus, so they're someone who we should test. So all that said, that's not what I'm here today to talk about. We're here today to talk about opioids, and it's an issue that I think is critically important. It's the defining issue of our time. I also think it's a real opportunity to lean into some things that we've neglected for far too long. So one of the hardest things about being Surgeon General is everyone wants me to make their top priority my top priority. I guarantee you if I went around this room and asked everyone, what do you think the Surgeon General should be working on, I get as many different answers as there are people in the room. So I want you to know what I'm working on and why I'm working on it. I picked community health and economic prosperity as an issue to work on. Number one, because the thing people most vote on, tomorrow's Super Tuesday, the thing people most vote on, Democrat, Republican, black or white, rural or urban, is jobs and the economy. So very important that we frame things in an economic lens so that folks understand that when we don't fund preparedness, it doesn't just cause health problems, it causes economic problems. When we don't pay attention to the opioid epidemic, we have a situation like we have right now where there are more unfilled jobs in this country than there are people looking for work because people checked out of the workforce due to disability and due to substance misuse. So we want to have healthier communities. If we want to have more prosperous communities, we need to have healthier communities. I'm also leaning into health and national security because the number two issue people vote on is safety and security. I hate to break it to you all, people don't vote on health. And that's not my opinion, that's the Gallup polls consistently over and over and over again. And some of you may push back and say, well, the polls I saw said that people vote on health care. Well, that's still not health. Only about 10% of your overall health is determined by your access to health care, number one. And number two, people aren't voting for health care because they're inherently concerned about health. They're voting for health care, voting on health care issues because 1/5 of our GDP is going to pay for health care expenses. 1/5 of the dollars coming in on their paychecks are going right back out to pay for health care expenses. It's still an economic reason that they're worried about health care. So we need to, again, frame health care and health in a way that resonates with people. And that's where my health and national security initiative comes from. 70% of our 18 to 24-year-olds are ineligible for military service right now. 70%. Because they can't pass the physical, can't meet the educational requirements to have a criminal background record. We need to help folks understand that if we want a safe nation, we need to have a safe and secure nation. Now, this issue is personal to me, substance misuse, because, and some of you know this, my own brother Philip is currently serving a 10-year prison sentence for crimes he committed to support his addiction. Surgeon General of the United States has a brother who's right now incarcerated due to opioid misuse. He suffered from untreated mental illness and unfortunately turned to drugs to self-medicate, starting with tobacco and alcohol, then marijuana, and then he went to a party and someone gave him a pill that maybe one of you all prescribed to someone a while ago. They ended up in their cabinet and got diverted, because we know that 80% of heroin users say that they got started with a prescription opiate, and most of those prescription opiates were diverted from somewhere else. But I share my family's struggle to illustrate that addiction can happen to anyone, even the brother of the United States Surgeon General. I also want to very quickly highlight that I've been on the other side of the opioid epidemic. I was the state health commissioner of Indiana when we had the largest HIV outbreak related to injection drug use in the history of the United States. And in order to really address an opioid-fueled crisis that was impacting rural Scott County, Indiana, we had to form strategic partnerships with local stakeholders. And I want you all to understand the importance of getting outside your clinic, getting outside your hospital, getting into those communities, because that's where health happens, that's where partnerships happen, and that's what you really need to lean into if you want to improve the health of your patients. And in Scott County, Indiana, by driving down there, 2 hours outside of the big city where my office was, into a rural community and sitting down with faith leaders, with the business community, with the public safety officers, we were able to implement a syringe service program, something that was quite controversial. Not just controversial, it was illegal in Indiana. But we were able to do that because of those partnerships, and we need more of you all to be willing to help forge those partnerships and leverage those partnerships. I want to talk a little bit about trends, because we've made strides with opioid prescribing across the country, and particularly here in Connecticut. One thing I would caution you about, I don't ever want people to brag about decreasing their opioid prescribing unless you're also telling me what you're substituting in its place. Because the opioid epidemic isn't the problem, it's the symptom. There is a real epidemic of untreated and undertreated pain in this country, and if you just pull opioids out but don't substitute something else back in, you're just going to keep playing whack-a-mole. And we saw people go from prescription opioids to heroin, from heroin to fentanyl. We're seeing them go from fentanyl to meth right now. So we also need to lean into tracking what we're doing to improve pain management. But talking about opioids, the Connecticut State Chief Medical Examiner reported 1,200 accidental drug deaths last year, a 20% increase from 2018. 1,200 people who aren't going to have Easter dinner with their families. 1,200 people who aren't going to see their loved ones graduate in May. 1,200 people who aren't going to go on to fulfill the potential that they had within them. And Hartford, with 133 deaths, led all communities within Connecticut. So it's very important that we lean into this issue. You have more people who are going to die in probably already this year, but certainly by the end of this year in Hartford from opioid overdoses than are going to be likely diagnosed with coronavirus in this state. Again, perspective. Perspective when we think about what we should be leaning into. So, what are we doing to respond to the opioid epidemic? I put out the first Surgeon General's advisory in 13 years, raising awareness about naloxone. So, audience participation, because I know you all have been sitting for a while. Raise your hand if you know CPR. So that's expected. Raise your hand if you carry naloxone with you everywhere you go. Anyone notice the difference in those hands? There you go. Fantastic. Can I hold on to that for a second? I keep mine in my briefcase, and so I go everywhere with mine. Intranasal naloxone. There's also an auto-injector version, Evio. The fact is, if you go out into downtown Hartford, you are more likely to be called upon to respond to an opioid overdose than you are to be asked to respond to a cardiac arrest. That's just the reality of the world we live in right now. You saw the difference in who was prepared if you got called upon to respond to a cardiac arrest, and who would be prepared with definitive treatment if you actually got called upon to respond to an opioid overdose. Critically important that we help folks understand that naloxone is safe, it's effective, and that anyone can get it from their pharmacy and carry it and be in a position to respond to an opioid overdose. And I didn't ask you to raise your hands to shame you. Once upon a time, there were people dropping dead of cardiac arrest, and it takes 4 to 5 minutes to get a anoxic brain injury. Most ambulances can't get to you in 4 to 5 minutes, so we said, let's arm the entire United States. Let's arm everyone to be able to respond to a cardiac arrest. Let's teach everyone CPR. We've been there before. We need to do the same thing with naloxone if we're going to turn around this opioid overdose crisis. In the community that I've been to as Surgeon General, they're starting to see a downward trend in their overdose deaths for the communities that started off by saturating their communities with naloxone. You can't get someone into treatment if they're dead. I also want to quickly talk about my digital postcard. And this lists 5 steps that every American can take to respond to the opioid epidemic. I love you guys. I'm going to leave you with some calls to action that are very specific to you, but I want you to understand that I don't believe, by any sense of the imagination, that this is all on providers to dig ourselves out of this hole. And we need to help communities understand the steps that they can take to respond to the opioid epidemic. I did this in the fashion of C. Everett Koop. Remember that guy?
Yes.
My predecessor, he put out a pamphlet called Understanding AIDS to everyone in America to help them understand the steps that they can take to respond to what was a crisis of fear, of stigma, of ignorance 30 years ago, the HIV epidemic. I wanted to do the same thing, except he sent his out via snail mail, and my kids say no one reads regular mail anymore. So we did a digital postcard. A digital postcard only works if you all share it through your social media channels, through your digital channels, if you print it out and share it. But talk about it. Most Americans, when we talk about an opioid epidemic, most people don't know what it is and it's not an opioid. Is Valium an opioid? Is Tylenol an opioid? Well, they told me Tylenol 3 is an opioid, so why is 3 Tylenols an opioid, but 1 Tylenol isn't? We need to help folks understand what an opioid is and it's not. Be safe. Only take medications as prescribed. Again, because the first drug dealer for most people out there isn't some shady guy in a back alley in Hartford. It's one of us. It's one of us who overprescribes to Aunt Betty, and then she leaves them in her medicine cabinet, and then during Easter dinner, her nephew comes in and rifles through the cabinets and takes them away. Takes them to a party and then gives them to my brother. That's how addiction starts in far too many communities. Understand pain. Treatments other than opioids are effective in managing pain. I said this morning at UConn. One of the challenges is, the saying is true, if all you have is a hammer, everything looks like a nail. All we've given our providers is hammers to treat pain. We need to broaden the tool chest. We need to help people understand that there are alternatives to pain, both on the patient and provider side. We need to pay for those alternatives, and we need to make it easier in care pathways for folks to utilize those alternatives to pain. No addiction is a chronic disease that changes the brain and alters decision making. Stigma is not just something that happens outside of this room. Stigma starts with us. Some of the most biased people who I run into are people who are in the medical professions. We need to understand that, yes, there are bad choices involved in many of these pathways, but folks, when they're under the influence of opioids, their decision-making is altered. No one woke up this morning deciding, hey, today I want to become addicted to heroin. We need to help put people in a position to recover. And then finally, be prepared with naloxone. So I'm going to finish with some calls to action. I want you to continue to be the leaders in this community and take steps that work. I know you're enhancing access to medication-assisted treatment, close-to-home MASH programs, and improving the treatment with telehealth support. So healthcare providers in the room, please take the free training. Please. We will not solve this problem with inpatient beds only. We will not solve this problem with only addiction psychiatrists. We need all of you to understand you have a role to play in helping us dig ourselves out of this hole. I actually challenged the folks at UConn this morning, because we were talking to medical students and dental students. I said, you wouldn't graduate someone from medical school or dental school who didn't know how to take a blood pressure. Who didn't know how to do the screening, brief intervention, referral treatment for hypertension. We say it's malpractice to graduate someone from medical school who didn't know how to do that. Most of the students in this community who are going to be going out and practicing, most of you all doctors, are more likely, or as likely at least, to encounter someone with a substance use disorder as you are to encounter someone with hypertension. So why is it that so many of us know how to treat hypertension, but so few of us are comfortable screening and referring people to treatment and doing brief and low-level treatment for people with substance use disorder. Partner and collaborate for success, and ask what role can Hartford Medical Society and this healthcare system play? What process changes can you put in place to change the culture, to lower stigma, to make it easier for clinicians to do the right thing? Look for ways to reach those who suffer from addiction. They're all around us. We need to take advantage of touch points. The ER is an important touch point. Your care encounters are important touch points to screen. And then finally, have the courage to make change. Be the innovators, be the disruptors. One thing I know for sure, we can't keep doing the same things and expect a different result, because that's the definition of insanity. So have the courage to change your care pathways, change your thinking, change the culture in your community. And if we do that, we will dig ourselves out of this hole, but we'll also prevent other holes from being dug in the future. So thanks for the opportunity to talk about this topic. You all can tell I'm passionate about it. We're going to get ready to have some folks come up and have a panel to help you better understand what's going on in your local communities to respond to the opioid epidemic. Thank you again.
At this time, I'm going to invite a few of the members of the Hartford Healthcare team. Pat is the president of Hartford Healthcare Behavioral Health Network. Pat. Dr. Craig Allen, who's a assistant leader for addiction service. And Dr. John Santapeter, who's a physician-in-chief for Hartford Healthcare Behavioral Health Network. While they're taking seat, I want to set the expectation for what we're going to be doing. We have time until about 1:30, 1:35 with Surgeon General at this time. And I'm hoping the panel discussion will last for about 10 to 15 minutes. And after that, we will have 1 or 2 questions from the members. Dr. Adams has expressed a wish to see the OR. We would need parachute to take you there and come back. But we have a special treat for you. We're going to actually have a SESI room ready to show you live robotic surgery in an OR, and you can communicate with the team as well at this time. The team's getting ready at this time, so we'll take you soon after this is done. If you want to grab a sandwich, we'll pack you one. Otherwise, you can take it when you go into the evening now. Thank you, all yours.
Fantastic. And I did request to go into the operating rooms. I actually am the first Surgeon General in recent history to still practice medicine. I still practice about a day a month at Walter Reed. The senator will appreciate this. I often say to folks, people say, what's the most shocking thing about being a Surgeon General? One of the things I will frequently bring up is how often decisions are made about health and healthcare without even putting anyone in special patient in ever, or at least in recent history. And to me, it's important that we engage with health providers and understand that something that was well intended in DC may not be playing out the way we think at the local level. So important for you all to get involved and to advocate. And that's a great segue to this panel. We want to figure out what's going on in the local community. And I'm going to skip the first question. We're going to come back to it because the second one is my favorite. What is going on in the community to address the healthcare crisis? And what is Hartford Healthcare and the Hartford Medical Society doing to better engage the community in responding to the opioid crisis?
Yeah, I think I can start with that. We at Hartford Healthcare, Rushford, which is the Center of Excellence for Substance Use Disorder and Co-occurring Treatments within Hartford Healthcare, have been working with our patients and in the community since 2011, providing opioid overdose education, naloxone distribution. We've also done a lot of work with first responders, and we've enabled the police in a number of different towns to carry naloxone, as well as security guards and school nurses, etc. We have a project right now going on in the city of Meriden. It's called the MORE Project. And what that project is when first responders go out into the community and they identify somebody who's overdosed on opioids and they've given naloxone and revived them, they will offer to take them to the emergency room. A lot of times people don't want to go to the emergency room. And they'll talk to you, you want treatment? And they say, I don't want any treatment. But what our MORE team does is we have a clinician and we have a peer who is someone with lived experience and specialized training to work in medical situations who will follow up with this person. And our clinician and peer have gone to some of the hotels on the Berlin Turnpike and met with people there. And there's one, I won't tell the story, but They don't just meet with that person where the accident occurred, but they meet with other people that see them there, and they're showing an interest, and they're offering support, they're offering help. The first time they meet with somebody, they rarely want to come to Rushford for treatment. But maybe we can help them in another way. And ultimately, we've been able to transition a number of these people, over 80 of them over the last year, to engage in one of our services. So that's one of the programs that we have going on. There's a number of others throughout the community that we serve, but I thought that was good.
I love that program because, as I mentioned, health doesn't happen in the hospital or the clinic, it happens in the community. That engagement, it takes someone, we put on Band-Aids, we catch people in safety nets inside our walls, but we need to get out into the community and reach people where they are, and that's a great example of it.
So I would say the other thing that we do that is about engagement that's been so successful is that through the Department of Mental Health and Addiction Services, the hospitals are funded to have recovery coaches in the emergency rooms. So the recovery coaches, as you know, are people with lived experiences. We have them in all of our emergency rooms across Hartford Healthcare, and we see about 60% of the people that they see get into treatment right away, and another 35%. Because what they do is stay in touch with the person. So if the person says, I don't want treatment now, the recovery coach continues to reach out to them to engage them in treatment. It's been enormously successful and actually saves our emergency department staff from having to deal with people with substance use disorders. And as you know, it's not always easy in an emergency room. Discrimination can sometimes be treated.
Well, and I don't want to pander, but I realize not everyone may understand what a recovery coach actually is or does. Like you said, someone with lived experience. It's one thing for a doctor, much less a surgeon general, to tell you, you shouldn't do this, or there's a better way, or let's get you into treatment. It's completely different when it's someone with lived experience who's been there, who can say, I know what you're going through. I know what you're feeling right now because I went through that same thing, and I want you to know that there's a better way possible for you. I remember a young man named Jonathan, who I met in Rhode Island when I was there. And Jonathan's father died of an overdose. His brother died of an overdose. Jonathan actually overdosed. He was administered naloxone and resuscitated, and he was ready to walk out of the hospital. And recovery coach was there and said, look, I know that the only thing on your mind right now is going out there and relieving this withdrawal that you're going through. But just sit down with me for a second. I've been there. Let's talk through this. And the short version of a very long story is that Jonathan himself is now a recovery coach. And so it's critical that we have those folks available at those key touch points.
I would just add, that's a great story. Education in the community and lots of naloxone, getting naloxone out there, training people in naloxone. Although your challenge with the image of flooding the community with naloxone, we're never satisfied with what we're doing, and I think we're going to be even more energized after that to do more of it. And then when you talk about CPR, mental health first aid is a very important part of what we do in the community, training people. As you said, people are much more likely to encounter somebody on a bus who's having a mental health crisis than a cardiac crisis. So thousands of people trained in mental health first aid, but again, still more to do.
That's a great segue to my next question. One of the things that I say often is that a long time ago, we cut the head off from the rest of the body. We said if it happens from here down, your primary care provider will see you now and your insurance card will cover it. If it happens from here up, whether it's auditory health, vision health, oral health, or mental health, we say, here's a card for a referral. It's a 4 to 6 week wait. Your insurance probably isn't going to pay for it. Good luck. You're not my problem anymore. And we need to think through how we reintegrate the head with the rest of the body. But the question I'd love for you all to tackle, and particularly for this audience, is what are you all doing in each of your roles to help make it easier for providers to do the right thing? Because providers inherently know that if we aren't dealing with your mental health, we're not going to be able to deal with your diabetes or your hypertension or all the other things that are going on. But they just don't know how to do it. What are you doing to make it easier for providers to do the right thing in regards to substance use disorder and mental health care?
So one of the strong programs that we have at Hartford Healthcare is a program that integrates behavioral health into our primary primary care offices. So we have either social workers or health psychologists that work in primary care offices or specialty offices actually, and screen for depression, anxiety, substance use disorders. And there are people in the audience that can tell you stories about increased compliance with diabetic medications, decreased hospitalizations, decreased ED visits. It works.
Right. You know, and another thing, and adding what I was saying, that's a great point. We have a opioid stewardship council here at Hartford Healthcare that was established in 2016 under the direction of Rocco Orlando. And the committee is co-chaired by Sherry Kroll, and Spencer Ermins, our executive sponsor. And it has doctors and nurses, PAs, and pharmacists from across Hartford Healthcare who come together and have been working on projects and creating educational offerings addressed at increasing safety and improving the quality of care we're providing for people who are at risk for opioid overdose. So some of the educational offerings have been safe prescribing of opioids, non-opioid pain management. And through this group, we've also done a data waiver training. Now we have over 100 prescribers with their certification. And we've worked with our electronic health record. As Jeff mentioned earlier, we have one Epic as our electronic health record. We've been able to put best practice alerts in place and different algorithms so that when one of our providers goes to prescribe an opioid analgesic for pain, they get a number of things to think about. Dose, size of prescription, alternatives, but also if someone is using a higher amount of this medication, think about naloxone. Think about a referral to pain management. Think about connecting with our addiction services. So we've been able to integrate. It was really the leadership of this committee and its ability to coordinate this project that has made a big impact on the system. The Behavioral Health Network in Hartford, we've been doing this kind of work since 2011, but pushing it out into the system really took people in the system that were motivated and energized to help do that.
Data waiver training, critically important. Indiana University, where I worked for the last decade, has about, is one of the largest medical schools in the country. We produce among the largest number of addiction psychiatrists every year in the country. And how many that is? It's 4 per year. If we tripled the number of addiction psychiatrists we produced, that would be 12 per year. That would put a dent in the access problem for the state of Indiana. But I ran the numbers, and if you look at the number of people in Indiana who have an Opiate number who can actually prescribe opioids in the state, and if half of them prescribed to 1 or 2 patients each, that would more than meet the need for people who need MAT. So I really am imploring each and every one of you, we don't need you to be an addiction psychiatrist. We don't need you to become the single person who takes care of 50 or 100 patients. We just need you to be able to take care of 1 or 2 of the patients who come in front of you who are low risk, and then be able to appropriately refer those folks who are high risk so that we can use our addiction psychiatrists more strategically in the future. Please consider becoming data waiver. It's 8 hours of training. Even if you never use it, you will be more informed to be able to recognize substance use disorder and have a conversation with people in the communities. Right.
If it's okay, I wanted to take your question and link it to something I thought was really powerful that you said, which was...
We call that bridging. That is a technique that I practice all the time. On Fox News this morning, I'm going to be on CNN tonight. If you don't like the question, you politely say, let me turn that around.
In psychiatry, we call it tangential. Because when you said that stigma starts at home, because it's easy to point the stigma finger at other people, but we have to look at ourselves and what we're doing in this organization. So, and to be up on stage with people that are national leaders here, and with you up here as well, realizing this is a national problem, we need to work nationally, but locally, in this organization, the culture of this organization, I just can't tell you how important it is that as a psychiatrist, there is not only do we not have the stigma and discrimination that you can find in other systems, there's something really special here. This place leans in. I mean, the fact that we're up here today, we lean in, and that's not just kind of cool. It's essential. If we're going to do this, we're going to do it as a house of medicine. We're not going to do it just in psychiatry. We're not going to do it, just as behavioral health and addiction. It's going to take all of us. So I just want to thank you for that.
We're being leaned in on. One more very important closing question for all of you. What resources are available in communities like truly rubber meets the road, practical resources that folks in this audience need to know about to connect a patient or a loved one with treatment if they think that they have an issue?
Oh, and his cell phone number.
Yeah, right. Call Rushford. We have the behavioral health number in Rushford have put together medication-assisted treatment close to home clinics. We have 16 of these clinics. They provide medication and therapy at the same site. They're located near our emergency departments, our acute care facilities, and our primary care facilities. The idea is an easy transition between these different types of programs. And we received a SAMHSA grant and a very generous donation from a local family to enhance our services there so that we provide telehealth. We have recovery coaches connected to those programs, and we're piloting a digital application to stay connected to our patients when they're not sitting home.
Fantastic. Anyone want to add resources?
I would just add, as I was saying before, walking into your primary care office, we're connected and integrated.
Fantastic. I finished my talk earlier by saying that insanity is doing the same thing and expecting a different result. We have a real opportunity here. We have a real opportunity in the midst of this tragedy to not just put out the fire, but to look at how we prevent the next fire. To lean into behavioral health, mental health, to lean into social determinants of health, to lean into adverse childhood experiences, to lean into building community resiliency. So